Taluk Hospital and District Hospital for any medical emergencies, including cardiac emergencies. There is no facility, no expertise, and obviously they have to move to a corporate hospital. Not that because today healthcare needs to be combinedly taken by both the public sector as well as private sector, but unfortunately non-affordable or less affordable cannot meet the expenses in this. On this line, we have given a proposal to the Honorable Minister. In fact, he discussed just previous day. The next day I get a call from his office that I need to give a proposal. We also gave it. So that lightning speed is acting. That is always nice, because that is how we should act while managing any emergencies, whether it is cardiac emergency or whether it is a neuro emergency or any other emergency. In fact, if for establishing a district hospital, 25-bed ICU, it costs just around 4 crores. 4 crores, and he has already chalked out how to mobilize resources. One from MP-led fund, other one is from MLA-led fund. 5% of deaths in India is due to cardiovascular disease, and 25% who suffer heart attack are below 40 years of age. In fact, on once, and also the rural-urban difference is narrowing down. So earlier we thought heart attack is a disease of elite class, city, a disease of cities. Is no more. It is equally increasing among poor people, among the even the laborers. So that is where. So ECG still today is a very simple, less expensive, and very diagnostic of heart attack and related problems. So this is where, because it is such a simple thing, less expensive, and easily it can be done and interpreted. One of the problems we are facing in the semi-urban and rural areas is lack of ECG facility, and also lack of expertise to interpret this ECG. And this is where the Tricog has made an innovative thing of screening. This is a mass screening. See, any measures that goes for a mass screening for any disease is commendable. See, here they have screened about 10,000 people in the community, and about 3.7% had some genuine emergency related cardiac problem. So this is extremely useful. Today, the social media, okay, it has many disadvantages. It has got good advantages also. Today, we are getting ECGs on our WhatsApp, from ECG taken in some semi-urban or some small clinics and some urban, some small hospital. They are being transferred on WhatsApp, asking for our, interpretation, asking for our, confirmation. So this is how we can facilitate an early diagnosis and early management of heart attack. Definitely this, because ECG is taken, they are transferred through the internet or the cloud system or a telemedicine system, and ECG within a fraction of a second. So you need not have, need not have an expert sitting in small clinics to diagnose this today. This, why it has got a lot of practical implication. Whenever somebody gets an heart attack, for every 30 minutes of delay in initiating treatment of heart attack, risk of death increases by 7%. So that is the reason we need to treat heart attack even in their own small hospital, whether it is a Taluka hospital or whether it's a primary health center, because the time is very, very important. We need to exploit the golden hour. So this is where this ECG, quick ECG transfer is going to be helpful. And on this line, we are going to facilitate this early treatment of heart attack in the Taluk hospital through what is called STEMI India, as well as Jaydeva is collaborating with that.
We have treated over 1.98 million patients absolutely free in the rural areas. Early days, I have never done an ECG. We have never had the chance to use these equipment. I'm very fortunate that recently we had the first exposure through Tricog. They conducted an ECG camp where they did over 1,000 ECGs a couple of days ago, and I was astonished to find so many of these ECGs were abnormal. These poor patients, whether they are old persons, ladies, they don't want to trouble their children. They don't want to trouble their family. They never tell you that they have a problem. They never tell you they have a very great discomfort. They come and take medicine for pain and go away and suffer in silence. Now, when we found so many abnormalities, I'm sure we'll take it further, and something solid, concrete has to be done. We have no access to an ECG. We have no access to a cardiologist. We have no access for medicines. We have no money. Where do we go? Now that's where Tricog can come to a great rescue of these rural poor. I'm sure when we convey this to the next in line for the care, and with help from great people like our Honorable Minister and Manjunath, we can take things further from there and to see that this reaches a logical end. I must take you back to 1973 when I was a house surgeon and I was practicing in Victoria Hospital. I always used to do the night duty in the emergency wards. Always most serious problems used to come in the nights. Always chest pain, sweating, absolutely weak, thready pulse, hardly recordable pressure. We had nothing to treat them even those days. So we had to put them on the stretcher and take them to the heart center. It used to be called Sirur Heart Block, which is now Jayadeva Institute, headed by Dr. Manjunath. So we had to push the patient on the wheelchair, not the wheelchair, on a trolley, and push them ourselves right up to the Sirur Heart Block. We had one ECG machine which would probably work, may not work, but with great difficulty we could get an ECG done and probably start them on whatever available treatment. It was that difficult way back in 1973 to even do an ECG. We had nobody who was so skilled to even interpret the ECG. Mind you, I'm talking about the nights in an emergency. Even today, if you go to any hospital in the nights, middle of the night, emergency, you find the junior most doctors will be there to attend you. Number one, you may not find a person who is competent enough or trained in a way to immediately identify the problem in the ECG and to tell us this is the diagnosis. So most important, crucial is to clinch the diagnosis. And the next step follows logically what to do for this problem. Where should we shift the patient? This must be done very quickly. That's the whole crux of the development in cardiology nowadays. Time is the most crucial factor. So exactly what the Tricog is now trying to do, exactly what Dr. Manjunath is attempting to do all the time. And from those days of Sirur Heart Block, now Manjunath has brought it up to such a great level. Thousands and thousands. He tells me in a day, 1,200 patients come to Jayadeva Institute of Cardiology. What a great service. Really, we are very fortunate to have him here, and so also Dr. Ranganath Naik. So with this gentleman, I am just stressing on there is such a dearth for people who can identify heart disease, such a dearth even to do an ECG and then go to the next step. So I am very sure that this new technology from Tricon will help us all, most importantly those in trouble, most importantly those in the middle of the night, even more important in the remotest parts of our state. Thank you very much. Have a good day.
Remote locations with the best ECG machine and a cloud connected device. And what we do, we bring the best of specialties which you will get, the best diagnosis that you will get in a tertiary center at every remote location machine. And a diagnosis of a heart attack can be made. It doesn't need a doctor to treatment to start right there at that peripheral center. This is what we have done, and over the past 1 year, 100,000 patients have been served by Tricon. 7,800 heart attacks have been diagnosed and their lives touched in some way or another. My request, our last speaker, Dr. Ranganath Naik, to give the closing comments.
So I thank the Minister for having brought in this very, very important and there's a lot of thought-provoking to the doctors, and it makes us think that what we have to do as we go along to make it better for our patients for delivery. There is always, of course, evolution of care. Now, one other thing is that all of us have spare. When Dr. Manjunath was sitting down here, I have been very, very fortunate to be a contemporary of his. We have both sort of grown in our cardiology careers together. But what he has done is something remarkable. I think in the last 2.5 terms that he's had at Jayadeva Institute of Cardiology, the delivery of cardiac care in Karnataka, I don't think it's Karnataka alone. It has changed the way cardiac care is delivered in the whole country. And we are all extremely proud of it. Extremely, extremely proud of it. The whole cardiological fraternity is extremely proud of it. Thank you, Manjunath, for what you have done. And it's just not delivering it to the postgraduate training. Now there are 20 postgraduates who are admitted every year there in Jayadeva Institute of Cardiology. That means those 20 people go to different parts of the country and spread this message of way cardiology has to be delivered to your patients. I think it makes a lot of difference. Research. Secret I would like to let you in. I think Charit has said Dr. Raman Rao. Actually, Charit is Dr. Raman Rao's son. Okay, and that's why he's the chip of the old block, as they say. Charit, we're very proud of 200 patients, then it's become to, and I know even now he sees from early morning to evenings 1,000, and everything is free. He supports it himself. There are a few people who back up his mechanism, who don't want to be identified, but the majority of it, he puts his own thing to help those poor patients with medications also. It's not just giving a diagnosis and saying go and buy this medicine. They are also given the medicines. And we will all be very happy, I'm sure, to support this particular technology. And then, of course, why we are all here today, Tricog. I mean, Tricog is a name, and which I think is bringing medicine and technology together to help improve the outcomes in patients and help, when I mean that, to improve their quality of life and also reduce the mortality in patients. All of us, Dr. Manjunath has said, heart attacks are very, very devastating on the family. And, many times deaths occur, as we said, as Dr. Manjunath said. Still, irrespective of the best of treatment, people die after a heart attack. If somebody says, if any of us as cardiologists say, no, I never see a patient after a heart attack dying, that means you're not seeing enough patients or we are not telling the truth. Patients die after heart attacks. Now the question is that, when a rural center, like Dr. Manjunath and me have been discussing, in a place like Gulbarga, small taluk headquarters, a patient goes, we want its diagnosis can be made, but what happens after that? They say, Nale pelige bani, because to do any further treatment, because there is no person to identify. Now, if that ECG can be identified, and then the next step is to give the treatment, a simple drug, as Dr. Charit said, aspirin, 4 tablets of clopidogrel, and a statin. If it's given, that itself brings down the mortality. If it's asked, the patient has to swallow it. That doesn't cost very much. And the next, go for an angioplasty immediately. A fast drug which can be given within a few minutes, which will bring down the mortality very significantly. But the only problem is the perception. Now, when we give, these patients may still die. Then they think that it's because the medicine was given that it's not. They don't think that the patient died because of the heart attack. They think they died because of the medicine.
Despite an heart attack, ECG can be normal in around 25 to 30% in the first 1 hour. That is the reason, if there is a strong suspicion that this gentleman has got an heart attack, we need to repeat an ECG after 1 hour or after 1.5 hours. Many times it has happened, patient comes with severe chest pain, ECG is normal, they say okay, go home, nothing happened, they have died on the way. So that is where one has to be, ultimately of course we need to combine the history. ECG alone, okay, it's helpful, but we have to take corroborative symptoms also into consideration. Doctors together to ensure that everything goes on smoothly.